So our next speaker is David Reyes, who's an associate professor in the, and interim dean, I might add, in the School of Nursing and Healthcare Leadership. And he has over 35 years of professional nursing experience in population and public health. He's the recipient of UWT's Distinguished Community Engagement Award and a whole bunch of other awards that I'm not going to read so that you can get going. He has a doctor of nursing practice and a master's degree in nursing and public health from University of Washington. And I will just let David take it away on your topic of exploring COVID-19 vaccine confidence and acceptance among BIPOC community.
Is this pointing at me or?
I'll move it. You
want to move it?
I'll move it. I didn't know you were going over there.
Yeah, we'll put everybody over there and then you can kind of.
Everybody
keep it lined
stays
up.
put, okay, that's easy enough. There you go.
And thank you too for the funding. So I'm going to talk about vaccine confidence and acceptance. And we might hear the term hesitancy a lot. And we're really shifting away from the term hesitancy because there's a lot of negative connotations. So we're really trying to understand really what's at the core of confidence in getting vaccines, and it really then actually sort of moving into action to actually get a vaccine. So I was fortunate to also partner, and I'll talk about my partners too, with the Tacoma County Health Department, and also currently with Asia Pacific Cultural Center. And the reason why we have been really trying to understand this is when we started looking at data around COVID-19 and vaccine, we really saw huge disparities. And we know that populations who are often marginalized, who come from low-income communities, who speak other languages, have harder times getting medical care in general, and then also having greater disparities in health outcomes. The other thing about that is that, you know, when we look at data are often aggregated in the big sense, and we don't really understand behind those numbers who are the people. And that's something that in terms of context is when I look at data, it is both qualitative and quantitative, and that really is the complete picture. In terms of then looking at COVID-19, particularly in Asia Pacific and Islander communities, that is a sort of ubiquitous category, social constructed category that we use, and we don't really understand what's the experience of those sort of sub-communities. And so we wanted to then sort of disaggregate and look really intentionally at some of those Asian Pacific Islander communities with these goals to explore attitudes about vaccination, to understand kind of what are the norms around intention, and then how can we understand the conditions associated with that hesitancy. I use hesitancy here more intentionally, but then how is it that when we think about vaccine acceptance, what can we learn from that? In order to do that, one of the theories and models that I've used here is called the theory of recent action. It's an old theory, but it's a theory and a framework that really looks at intentionality. To help us understand belief systems, so what we call attitudes or behavioral beliefs. And we all have our individual belief systems, but we also know those are influenced by a lot of internal and external factors. And so this theory wants us, or allows us to then begin to explore what are some of these normative beliefs, in other words, influencers. Those might be people, those might be economic conditions, a whole host of sort of socioeconomic factors. And/or pressures. In other words, when we're thinking about engaging in a particular behavior, we might be influenced because of things around us. So really our intention might be one thing, but we act in another way because there are these sort of competing intentions or influencers. And then looking at then how are we then engaging actually in the action or the control? In other words, do we actually have agency to then actually make a decision, in this case, to actually get vaccine? So this is a theory that I've been very familiar with for many years, and it's also part of the social behavioral theory. There's another part of this which then actually goes into planned behavior, and that's sort of the extension of this that I'm not going to get into, but this is really sort of the foundation of when we try to collect information from individuals or communities about how they engage in health behaviors. So my partners, again, were the APCC, Asia Pacific Cultural Center, the Tacoma County Health Department, using mixed methods. I'm going to talk more today about sort of the quantitative survey side, but the background to this is that over the last year, worked with the health department to facilitate listening sessions with different communities. For example, the Marshallese community, the Samoan community, Filipino community, and others. And to then understand sort of experientially what were they experiencing during the COVID-19 pandemic in terms of how were they actually engaging in health behaviors and how could they actually get a vaccine. This particular study also included a survey that I will talk about in a minute. I think the important thing then is that when we were doing this, this work using community-based participatory research approaches. In other words, really engaging the community and actually leading this work. So what we did and what I did was help to also train community members to actually facilitate listening sessions. And so that really brings the onus of control and empowerment back to the community. And as researchers or as health department folks, that we're there to support the community to understand what's going on in their particular communities of interest. And then to collect that information and then also incentivize them, actually give them an incentive for actually participating and not just sort of freely giving their time, which is also very valuable. So core to our community-based work is also recognizing that nobody's time is free. So they were compensated for their time. So I'm going to talk about the preliminary results from the survey itself. And there were demographics questions that I'm not going to get into, but there's sort of the three domains that I talked about. One is around behavioral beliefs. So there were three questions that we asked here. And in this case, these sorts of questions are on a 7-point Likert scale, which seems like a lot, but when you're looking at refining the data, you really get a better spread of how people are making decisions. And in this case, these are all mean reporting results. So this first question was about the importance of actually getting the vaccine to the individual. And how important was that individual, or in this case, in this group of Samoan community members, how important was to actually get approval. So in this case, people most important to me. So when we think about our communities and people that we associate with, peer pressure, family pressure is really important, right? We all know that. And so if we're looking at living in a community, how am I actually potentially being influenced by the people around me? And how much do I want to be like them or not? Okay. So this section around behavioral beliefs really sort of allows us to understand on an individual level the importance of not only the health behavior, but who around them is actually beginning to influence them. So getting the vaccine to protect me against COVID-19 is, in this case, this was a question about, is it good or bad? But in this case, we asked, is it very positive or is it very negative? And in this case, they're saying somewhat positive to positive. So it's somewhere in between. And then my getting the vaccine will result in protecting me from getting the virus. Now we know that in this last 2 years, there's been a lot of different information out about the vaccine, right? Misinformation. And so this is a really important question because it also tells us whether or not people actually believe in the efficacy of actually getting vaccinated. And that's a part of this model, is how do we begin to understand self-efficacy and then intentionality to actually engage in the behavior. So it's interesting that when I look at this, that, if you sort of see somewhat agree along on all of these means versus sort of on one extreme or another. But, the N is only 12, so it's not huge, and we're going to be doing some more. But when I look at the mean and the mode of these, we really do see more extremes. Some people say, yes, I completely disagree with this, or maybe I agree completely, right? So we have to understand this more fundamentally. The next domain is around normative beliefs. So this is where we're beginning to look and understand what are actually influencing people's decisions. And in this case, what do their families think? What do their friends think? And how are they actually then influencing them to say, stay healthy, to get vaccinated, and or, you know, how aligned are they again with the pressures that are around them, whether it's family or whether it's friends, right? And this is really important, particularly in API communities, because in immigrant communities who are actually living together. And that was something when we were looking at some of the data, is to understand when we think about interventions, how do we actually tailor interventions to meet the needs of a particular community? Just anecdotally, when we were talking with some tribal members about this, something that the health department learned that I actually explained to them is that in the normal convention of vaccines, we went to all those folks who were most high risk, right? Those who had underlying conditions, age, et cetera, and we went kind of like one by one to say, you get vaccinated, you get vaccinated. But if you're in the family and you don't qualify because you don't fit under the age range, then you're also at risk, right? So that creates other conditions again for actually not even abating the epidemic. But what we learned from some tribal community members was that they actually vaccinated their family units. So they actually had a protective factor, which is against the normal Western view of doing medicine or health, right? So there's key learnings when we think about Indigenous and communities of color who are actually acting in different ways to protect themselves. So again, we have a lot more to understand because here people are sort of agreeing and disagreeing. And in some cases, they may somewhat agree about whether people are actually influencing them, whether they're families or whether they're friends, okay? This was the second set of questions. In this case, how important was it to stay healthy? How important was it that their family members wanted them to get vaccinated? And again, did they want to be like their families? Did they want to be like their friends to stay healthy? Again, they're sort of in the middle. And so we need to expand our work here to understand at a broader level what that really means. And then these control beliefs, which is about how often they got information. And this is really important because now we're also getting into the flu season. And this is another confounder, is that it's not just about protecting against COVID-19, it's also about the other now conditions. And now that we are more socially getting together, we're also being exposed to those things that we weren't in the last 2.5 years. So understanding as well, and this is what we're expanding to, is how are people also thinking about now getting the flu vaccine? And do they have enough information to actually make that decision? One of the things that we'll have to now tease out too is then where are those sources of information? And who do they trust the most? And this is one of those control beliefs. And then when we think about self-efficacy, is who do they trust the most with information to actually make a decision? There's very little research that actually tells us, when we think about using the term healthcare worker, who do they trust within that healthcare workforce? Is it a physician? Is it a nurse? Is it a social worker, et cetera? And particularly in communities that have been marginalized, to be able to understand who are those trusted messengers that can then actually facilitate them getting vaccinated. So where we're headed next, we're going to do some more deeper analyses because we looked at different socioeconomic factors, socially constructed race, age, gender, income level, as well, to understand are there any correlates or based on those sort of categories. We're also expanding this, so I also have some additional surveys from Filipino elders. So because this N was only 12, we'll be aggregating all those data to see if we can look at if there's any sort of power to any of the findings that we find. The other thing that we're doing right now too is actually to include LGBTQ plus community members, and particularly in Asian Pacific Islander communities. This week, we're actually going to be doing focus groups with trans community members here in Pierce County, because again, we think about the intersectionality of our identities, and then we think about healthcare and health intervention. Again, there isn't a one cookie cutter approach. We want to target to API communities. Even within API communities, there is a lot of diversity. So that's where we are out at, and I am done.
Okay. Okay, one quick question for David before we move on. Anybody have a question? So how many communities are you doing total, David? Sub-communities, right?
Yeah, so we've been working with Samoan and Filipino, and particularly Pacific Islander communities. We earlier did some listening sessions with the Marshallese community as well. So really focusing on API.
And they're all like Pierce County, Tacoma.
Well, so this is the other thing about geography, that communities don't necessarily define by zip code.
Right. That's why I'm asking.
And so we've had crossover
Yeah.
between particularly South King County and Pierce County.
Cool. Thank you.